I'm actually going to pass this over to Nav to talk through our anemia management model, and then we'll go back into some other of the AI features in the application.
Oh, thank you, Ryan. So I'm excited to talk about this feature because I think that this is such an important and costly part of providing dialysis care. And obviously, the medications for anemia management are high-cost medications, and we want to be efficient in that regard. But getting the hemoglobin wrong on the high end and on the low end is also costly for the patient perspective. The patient transfusions have a lot of morbidity, and we all know that very high hemoglobins can lead to fistula clotting, MIs and strokes. So we really want to keep the hemoglobin stable and in a tight range. What we decided to do for this was to go with individual anemia treatment. So we started with Mercera, which is the most commonly used treatment across patients who are part of the Dialysis Manager cohort, and then we're going to Epogen or erythropoietin next. So I want to show you an example of Mercera. So here, if you look at the first row, this 69-year-old female who dialyzes 3 times a week is on 60 micrograms every 2 weeks. The last hemoglobin is 10.1, but our algorithm is suggesting a dose of 75 for this person. So why is the algorithm suggesting a dose of 75, and how does it know how to suggest the right dose? Well, the algorithm does a lot more work than just looking at the last hemoglobin. We're taking the 90-day history of all the previous hemoglobins, the trend, whether it's going up or going down, the ferritins, the TSATs, the albumins, the demographics of the patient and their history, and we're using all of those variables that are nearly impossible to compute in your head, and making a recommendation that this person at 10.1 should go to 75. I want to show one other example, which I think is worth showing, and that's on row 4. So on row 4, we have a 76-year-old female, and this person is also 3 times a week, and they're on 100, and their hemoglobin is 10.4. Now, with this 10.1 person, we went to go 60 to 75, but with this 10.4 person, we're going from 100 to 75. So we're actually lowering the dose. So the reason I wanted to show these 2 examples is because there's much more to the story than the most recent hemoglobin. So if we just react always on the most recent hemoglobin, we'll kind of not capture the entire picture. And what we've shown with this Mercera model that'll be available very soon is that we can keep people in the target range and the KDIGO target range better. And not only that, we can achieve up to 8 to 10% of dose reduction and sort of direct cost savings on the medication used. And I think many would say that cost savings on Mercera also equals better outcomes for patients, right? Because if we can keep the patient's hemoglobin stable while using less drug, I think that's better for cardiovascular health and fistula health.